Respected panel of experts and audience, Assalamu alaikum. I am Dr. Mohammad Jaman, going to present my paper on angioplasty and stenting of symptomatic basilar artery stenosis. We all know stroke is the second leading cause of death across the world, and the prevalence of stroke, especially ischemic stroke, is increasing steadily in developing countries like Bangladesh, and intracranial arterial stenosis due to atherosclerosis accounting 30 to 50% of all ischemic stroke among Asian population. The outcome of postcircular stroke, especially symptomatic basilar artery stenosis, is very poor. Most of the patients, despite optimal medical management, significantly showing morbidity and mortality. For this, surgical treatment is demanding, but unfortunately, it has considerable morbidity and significant rates of complications and failure. Angioplasty of basilar artery stenosis has been proposed as a novel therapeutic approach, and a new generation intravascular flexible stents is capable to navigate the tortuosity of the vertebral artery and may provide a new therapeutic approach with encouraging results. After an initial series of basilar artery stent angioplasty indicated a high technical success rate and minimum morbidity. We describe a patient with angioplasty and stenting for symptomatic atherosclerotic stenosis of basilar artery. This patient, Mr. 40 years old gentleman with history of prolonged hypertension on irregular medication, presented with history of recurrent vertigo and repeat drop attacks. Recent MRI showing there is left pituitary infarction, and MRI showing there is significant mid-basilar stenosis. Patient was on double antiplatelet therapy, but patient still continue to experience daily episodes of vertigo and frequent drop attacks. Cerebral DSA confirmed there is presence of high-grade middle basilar artery stenosis. We go for cerebral DSA followed by angioplasty and stenting. After insertion of 7 French femoral catheter, femoral sheath, 5,000 unit of heparin was given, and then 3,000 unit is given per hour, and patient was given loading dose of aspirin and clopidogrel 6 hours before the procedure. Then a 7 French envoy catheter was placed in the proximal tortuosity, proximal part of the vertebral artery. Then a guide was placed and navigated across the stenotic portion of the middle portion of the basilar artery, and it is placed on the left PCA. Then a balloon was placed and inflated. Then a 3.5 into 18 low profile visualized interluminal support stent junior was deployed to maintain the patency of the middle basilar artery stenosis. This low profile visualized interluminal support stent was used for stent assisted coiling, but it can be used in case of basilar artery stenosis. The stent was deployed here. post-stenting angiography revealed there is restoration of the circulation. Patient was discharged with double antiplatelet and rosuvastatin. After 6 weeks of follow-up, patient was completely free from his illness, no drop attacks, no vertigo. We all know, in spite of intensive medical management, patients with high-grade symptomatic intracranial atherosclerotic stenosis are still refractory to aggressive management, and the yearly stroke rate is very much high. And endovascular treatment with balloon angioplasty and deployment of stent is considered an alternative choice with encouraging outcomes for treatment of high-grade intracranial stenosis. Yet, arterial dissection, interplug dislodgement, and or elastic recoil is a frequent sequelae of only balloon angioplasty. Then stent is required to stabilize the concerning vessel segment. This LV IS stent is a newer neurovascular self-expandable and retrievable with great radial force and with great appositions of the vessels. Despite a significant incidence of ischemic and non-ischemic complications after basilar stent placement, our patient achieved freedom from vertebral basilar artery symptoms, and this braided LVIS stent can be safely applied for the treatment of intracranial atherosclerotic stenosis with good safety and efficacy. However, randomized control trials and double-blinded design and involvement of multiple medical centers and ethnicities should be performed in the future to confirm the safety and clinical effect of this LVIS stent. Acknowledgement, special thanks to Professor Kazi Muhibur Rahman sir and ATM Hasibul Hassan for advisory supports and helping to perform this exclusive work. And also thanks to Professor Sharifuddin Khan, Dr. Siraj Islam, and Dr. Amin Hussain, and Department of Intervention Neurology, NIMS. Thank you all.